All right, so we are recording. Just a couple of updates is if anybody here or is listening to the recording is planning on taking your exam this coming Friday, please make sure you go in and fill out the Google form before the deadline, which I think was like 5 o'clock on Thursday, and we'll get you taken care of. I think you guys are at like, I got another report on the course evaluations. I think you're like up to 60%. So encourage your fellow classmates to do that. They closed it out early last year. It will close out on the 4th, according to what they say, unless they close it out already. So if you have not done that evaluation for 305, please go in and do it as soon as you can. Any questions that you have for me, Allie?
Do you want us to fill the exam form out for taking it at the regular time?
If you're taking it the regular time, no. Only if you're going to take it on Friday. So yeah. So Allie asked if they need to fill the exam form out if you're taking it at the regular time, and the answer is no. So only if you're taking it on Friday. Anybody else? So the plan for today, the plan for Wednesday is twofold. Number one, we're going to cover questions that are similar to what you're going to see on your final exam. And so we're going to strengthen up any weak areas of content that you might have. And the second thing I'm going to do is beginning with this exam and working all the way through the summer, we're going to look at how to take a National Registry type exam. Now, you guys are going to see a brand new exam once you go take it. Don't let that freak you out. Actually, it's a better exam than what is out there currently now. So you will begin to see several different types of questions in the summer for all the testing that you're going to be doing. So as we go through here, one of the things that I want to do is let's just take a look at these questions. And again, the thing I want you to do is you got to be very careful about reading the questions. One of the things that I'm seeing with folks is that they are just going through a 60 question exam and taking it in 30 minutes. That's one of the reasons why the scores were so bad on the last exam. There were some problems with the exam. There was problems with the exam that existed the last time will not exist with your final exam because I've already gone through and vetted it. But take your time and read it and understand what is being asked in the question as well as understand what is not being asked. And I think that'll become clear as we go through and we look at this. So here's our first one. So Austin, this is going to be yours, all right? And this is what I'm going to do. We'll take a question in person. A 34-year-old woman presents with complaints of vaginal bleeding and pain during intercourse. Her last menstrual period was 2 weeks ago and was reportedly heavier than normal. She reports that she has saturated 2 menstrual pads in the past 2 hours. You should. Now, anytime you see you should or what should you do or something to that effect, both on my exams and the registry exams of these 4 things, what I want you to do is to pick the one of the 4 that you're going to do immediately next, okay? So that phraseology is critically important at the end of your question. So you should A, assess vital signs in transport, B, apply oxygen and start a large bore IV, C, advise her to insert a tampon to control bleeding, or D, ask her if she has a family history of uterine cancer. Now, Austin, what I want you to do is I want you to eliminate 2 of those answers that you feel with an 80 to 85% certainty are incorrect.
Get rid of C and D.
Get rid of C and D. So we'll take those out. All right. So we're left with assess vital signs in transport or B, apply oxygen and start a large bore IV. Tell me why you're going to go with A. And you're going to hear me say this a lot of explain to me why you chose the answer that you did.
I guess the question doesn't give me any vitals to say, hey, she needs oxygen. and you can't assume, right?
Nuh-uh.
So if there's no vitals in the question, I need vitals, and then I'm gonna assume it's like a some type of pregnancy complication or bad menstrual cycle thing. So it's like not the most critical thing in the world. So
Okay.
looking at vitals and transporting seems like that's
So yeah, you did really, really well on that one. And this is how you break this question down, okay? And we look at this, and much just like we would see in here, we have a female with complaints of vaginal bleeding and pain during intercourse. Now, one of the things I would tell you in this regard, this is definitely not a pregnancy problem. Anybody got an idea of what might have caused pain during intercourse for this lady?
Pelvic inflammatory disease.
Maybe, but now remember, with pelvic inflammatory disease, does it come and go? So it is constant. What else do we know about PID as far as the pain that this patient would have if she had PID? Yes. It is diffuse, okay? So it is diffuse. And the second thing is, what does movement do for the PID patient? It makes it incredibly worse. Remember, we talk about the PID shuffle, just walking across the floor. So, not to be crass, but there's probably no way in the world that this lady is going to be able to have sexual intercourse just simply because of the pain that she was in if she was in PID. What else might cause pain during intercourse?
during cyst rupture.
Bingo. Right there you go. Right there you go. Okay. Now, it is possible that she's pregnant, but again, we don't know that because her last menstrual period was 2 weeks ago. She's not late. Okay. It does report as being heavier than normal, so it could be a menstrual problem. But again, in this particular situation, what Austin did is exactly right. You look at the scenario and you don't assume anything. When you're looking at the question for a registry type exam, only go off the information that is in there. Now, obviously, you guys are going to be great clinicians, and literally, you're going to be thinking two things. Number one, you're going to be multitasking. Number two, you're going to be thinking, well, if this happens, then this, and this could be it. Or if this happens, then this, and this could be it. You got to kind of turn that part of your brain off when you take these types of exams, Thomas, because literally you can't play the well, what if game. So only look at the information that is provided in the question and select your answer based off of that. Any questions on that or how we go on it? That's a really, really good start. All right, Tom, this is yours. Your patient is a 7-month-old boy whose mother called because he suddenly became lethargic and pale. He's in this rhythm. Now, first of all, I want you to do, what is that rhythm? Okay, so we've identified the rhythm. His extremities are mottled and his capillary refill is 4 seconds. Which of these should you do first? A, adenosine, 0.1 milligrams per kilogram, rapid IV push, repeated at 0.2 milligrams per kilogram if unsuccessful. B, adenosine, 0.2 milligrams per kilogram, repeated at 0.4 milligrams per kilogram if unsuccessful. C, synchronized cardioversion beginning at 2 to 4 joules per kilogram. Or D, synchronized cardioversion beginning at 1/2 to 1 joule per kilogram. Now, Tom, kick out two of those that you feel like are probably wrong.
B and C is the wrong dosages.
Which ones?
B and C.
So we'll take B out. We'll take C out. Now, of the ones that are left, A and D, which one do you think is the most appropriate?
A, because his cap refill's not that bad.
Okay. Now let's go back here and look at it, and let's make sure you got all the information. Look at this right here.
Okay, probably synchronized cardio right
So why synchronized cardioversion the better answer than A?
Because he was in a worse condition.
Good. So again, make sure that you're looking at all. Is this of all the information? Is this patient stable or unstable? Unstable. What makes this kid unstable? Bingo. He is lethargic and pale. So we've got blood shunting that is occurring as a result of shock that's going on. So again, in that situation, what we would do is that we would go with synchronized cardioversion. Here's the thing I want you to remember. If you want to, or here's the thing I will do. I will provide you with drug dosages for everything that may be referenced on this exam, with the exception of epinephrine and atropine. I expect you to know those two drugs, okay? Any other drugs that will be referenced in here, I will give you a sheet, or I'll include it in the exam of what those are. We give pediatric drugs so infrequently, I'd much rather you look it up, okay, with the exception of epi and atropine, all right? Any questions on why we would cardiovert this kid? All right. Come over here. Which of the following is true of Mittelschmerz? A, it's typically located unilaterally in one of the upper abdominal quadrants. B, it's usually accompanied by heavy vaginal bleeding. C, it's associated with ovulation. Or D, it's a sign of ectopic pregnancy. Now, Joe, kick two of those out for me, please.
D.
You say B, Bravo?
B and D. Yeah.
All right, we'll take B out. We'll take D out. So of A and C, which one do you like better?
C.
Okay, good. Mittelschmerz, not a life-threatening emergency, normal occurrence of biology, but again, I want to make sure that you know what it is because I've seen on some of the exams that I've taken, as well as some of the exams that I've helped develop for registry, is that question is in there. I'm not going to say frequently, but it's in there not infrequently as well. And basically, this comes about as a release of the egg during ovulation. The lady will generally have some type of left or right-sided pain, usually only one quadrant and only one side or the other. This generally will last for about 24 to 48 hours, and then it goes away. Good. All right, Sam. 16-year-old girl has been complaining of abdominal pain, nausea, polyuria, and polydipsia for the past 4 days. She has no significant medical history. You suspect she may be suffering from A, ovarian cyst, B, diabetic ketoacidosis, C, meningitis, or D, ectopic pregnancy. Take two of them out.
Probably C and D.
We'll take C out. We'll take D out. So of ovarian cyst and diabetic ketoacidosis, which one do you think is the most likely?
B.
All right. Tell me why.
Because she's got the polyuria. Ovarian cyst wouldn't explain that.
Okay. What's polydipsia?
Drinking a lot.
Yeah. Okay. So again, let me ask you a question. If she has diabetic ketoacidosis, is this most likely as a result of type 1 or type 2 diabetes? 1. Why? You're right. Tell me why you're right.
Usually it manifests in children from the first time that they start to become like the symptoms that it shows.
Excellent. Very good. Understand, especially in certain cultural populations, type 2 diabetes is showing up at younger and younger and younger. Again, I think I shared with you sometime back about a year ago, I went to a pediatric conference down in the Smokies, and there was a guy there, a medic from Cherokee, North Carolina. He says they're seeing type 2 diabetes in kids as young as 12 now, not type 1, type 2. And so, but the big thing is here, the DKA is most frequently associated with type 1 diabetes, not so much type 2. All right. Good job. Very good. All right. Jonah. 22-year-old woman presents in moderate distress, complaining of diffuse lower abdominal pain. The pain has become worse for the past 2 weeks, and she's now unable to walk without an increase in pain. She has severe pain with palpation of the lower abdomen and the following vital signs: heart rate 102, blood pressure 118/74, and respirations of 20. Which of the following would most indicate the presence of pelvic inflammatory disease? A, my boyfriend was just diagnosed with chlamydia. B, I just had an IUD inserted. C, my last menstrual cycle was normal. Or D, I have chronic urinary tract infections. So take 2 of those out for me, please.
I'll take B and C out.
We'll take B out. We'll take C out. All right, so you're left with A, you're left with D. Which one do you like better?
Like
Okay, so yeah, PID is almost always caused by some type of STI, sexually transmitted infection. Okay, and again, this is a good picture that is painted in here of what this lady would present like. Now, as we can see it here, like we talked about, she's unable to walk with an increase in pain. Going back to our very first question, that's how we can pretty much safely rule out in that she had any type of PID because of sexual intercourse, because just the simple act of walking intensifies this pain. Allie.
Can it also be caused by UTIs?
It can, but now remember, here's the thing that it's asking. Most indicate PID is almost always, not always, but almost always caused by some type of an STI. Can it be caused by a bladder infection? Absolutely. But generally what we would see in females that would have PID from a bladder infection is that they would have a decreased immune system, either from a disease process or potentially from an organ transplant. Good question. Anybody else? All right. Alexis, which of these best describe Pierre-Robin syndrome? A, a congenital condition characterized by a small jaw and large tongue in conjunction with a cleft palate. B, a condition in which the ductus arteriosus fails to close completely until age 2. C, repeat febrile seizures within the first 6 months of life. Or D, persistent pneumonia following meconium aspiration. So take 2 of those out for me, please.
I don't remember what that syndrome.
We briefly talked about it, but now let's think about this for just a second, okay? When you're in a situation of, you're not entirely, this is one of the reasons why I've got this in here, because I want to dig into it a little bit deeper. When you're not entirely sure about the answer for a question, go in and eliminate the ones that you know that it can't be, because if you do that, when you have to guess, you increase your chances from 1 in 4 to 1 in hopefully 3 or 1 in 2. So which 2 of these do you feel like that it could not be? Because we did discuss some of the others.
I guess.
So we'll take out A. And did you say D? Okay. So of B and C, which one do you like better? Okay. So in this situation, it's actually going to be A. And again, it's okay. We did not hit this as deep as what we should have, but that's why we're coming back to it today. So Pierre-Robin syndrome, or sometimes you'll hear it pronounced Pierre-Robin. It is basically a child that has just a really small head and a really small, particularly lower jaw, that will have also a large tongue. In some situations, there will also be some intellectual delayed or developmental delay for this child as well. The big thing that we're looking at with Pierre-Robin syndrome is that we want to watch them really, really closely for airway obstructions. Again, because they got basically a small mouth, small head, and a really big tongue, which in essence is their head does not develop in the same process or the same speed as the rest of their body, which puts them in the same category as what we would worry about with infants. All right. Ductus arteriosus, we'll talk about that in just a little bit. Ductus arteriosus is basically where you get oxygenated and deoxygenated blood that mix together, and that can be fixed really, really quickly. Repeated febrile seizures, no big deal in that one. And then persistent pneumonia following meconium aspiration, that's just simply a potential for meconium aspiration in all infants. Now, Pierre-Robin is generally seen once a child begins to get into the toddler age. Okay. Any questions on that before we leave it? All right, Bella. 37-year-old, obviously pregnant woman complains of sharp tearing abdominal pain. She reports that she's pregnant with her fifth child, but states that she cannot remember the exact due date. The patient has a history of drug use and states that she last smoked crack cocaine approximately 30 minutes ago. Mother of the year, not so much. You suspect A, spontaneous abortion, B, placenta previa, C, abruptio placenta, or D, false labor. Take two out for me.
I'll get rid of B and D.
We'll take B out. We'll take D out. Which one do you like?
C.
Say C. So why did you choose C? It's the right answer. Why did you choose C?
Because it said the sharp tearing abdominal pain.
That's one thing.
I just know, like, with false labor, it wouldn't be, like, tearing, I guess, and placenta previa, that, I just don't think any of the other ones would be really tearing. And
Okay.
spontaneous abortion could be it, but a lot of times they're painless or don't have that much pain going along with it.
All right. So let's look at this a look. You did a good job on that one. So let's look at some of the other things that's here as to why it could be abruptio placenta and not one of the others. Now remember, abruptio placenta is painful and will often have bleeding. Here's the thing. There's no mention of bleeding in here. Why? What has to exist for this to be abruptio placenta, but no bleeding? Anybody?
It just detaches from the wall.
What part? You're right. What part?
Forgot what it's called.
Okay. What part of the placenta detaches from the wall that would prevent bleeding from being present? So remember, okay, let's say my hand is the uterus. Here is the placenta that's attached, right? If it begins to tear off this way, we're going to have painful bleeding because now the blood is being able to escape. But it is possible for it to begin to tear from the middle with the margins of the placenta to remain intact, which basically means the patient's still bleeding, Joe. You just don't see it. It's still intact in there. What else in here gives you a clue that this, of these four options here, is most likely going to be abruptio placenta? Hallie?
Fifth child.
Not so much the fifth child, Joe.
Stimulant usage?
Why? Stimulant usage is right. Now tell me why.
I don't remember the exact reason. I just remember it was there with.
Okay.
Synthesis.
Bella.
Maybe it's because it was just so, like, recent that she did it, so something just happened suddenly.
So keep in mind, not only is it recent, but she's also got a chronic history of it as reported. Now, here's the thing with abruptio placenta. Two things that increase the possibility for an abruptio. Number one, hypertension. Okay, so if mom has a history of uncontrolled hypertension, it can actually cause that placenta to tear away. The second one is amphetamine use. Why? Because the amphetamine use increases the sympathetic nervous system. And Tom, we have an increase in the blood pressure, a dramatic increase in the blood pressure when someone uses an amphetamine. So the fact that she has been using cocaine for a while and she just did it 30 minutes ago and now she's complaining of this sharp pain is most likely going to be that. Spontaneous abortion, we would see bleeding with that as well as the possibility of some tissue that's coming out. Placenta previa, we would generally see some bleeding, but there would be no pain, okay? False labor would, tell me, why would it not be false labor? Alec.
I don't know if it says, like, it kind of indicates, like, that it's, like, consistent pain. With false labor, it would come and go.
Bingo.
Contractions.
Yep. So basically, the question in here is indicating that the pain is consistent. It is going on the whole time here, and so basically, what we're looking at is going to be this whole situation of the patient having an abruptio placenta. Now, let me stop here for just a minute. In particular, for these four particular conditions, does anybody have any questions about the signs, the symptoms, as well as what can bring them on? Bella.
Is there any way that like placenta previa increases like the chance of happening increases with anything?
Placenta previa basically will begin as we would see this in late term gestation as a cervix begins to dilate. And what we see with that is that, again, because it's painless, because not a lot of nerve endings in the cervix. There are some, but there are no nerve endings in the placenta. So there's not going to be a lot of pain. As the cervix begins to dilate, when mom is getting ready, the body is getting ready for the delivery process, it begins to pull away from that. So early on in the last trimester is where we would begin to see that. As far as anything that would increase that, any type of straining or stretching could make it worse as well. In many situations with a placenta previa, mom is put to bed until her pregnancy is over. Good question. Anybody else? Allie.
How would you differentiate the abruptio between that and the abortion?
So with the spontaneous abortion, you're almost always going to have blood and or tissue parts. With the placenta previa, you will have blood but not tissue parts, because the abortion is literally the body expelling the fetus out. With abruptio placenta, it's just simply the placenta pulling and tearing away from the uterus. Very good. Anybody else? All right. Let's move on. You guys are doing well. All right. 20-year-old sexually active woman presents with severe right-sided abdominal pain that radiates to her back. She states that the pain came on sharply during intercourse about 15 minutes earlier, and she reports a small amount of vaginal bleeding. She states that her menstrual cycles have been irregular for the past 3 months. The most likely clinical diagnosis would be A, ruptured ectopic pregnancy, B, ruptured ovarian cyst, C, spontaneous abortion, or D, pelvic inflammatory disease. Zach, this one's yours. So what I'd like for you to do is to take out 2 of those, I don't know why that keeps showing up in there. That you feel like are incorrect.
So her menstrual cycle's been irregular, but she has been having it.
So again, just you can only go on what is presented in the question.
I'd probably get rid of spontaneous abortion and ruptured ectopic pregnancy.
Okay, so that leaves us with B and D. Which one do you feel like is the better answer of those two?
Probably ruptured ovarian cyst.
Okay, why are you right?
With PID, you're looking at more diffuse pain, but with ovarian cyst, it's either right or left sided usually.
Excellent. Good job. Okay. She's got right-sided abdominal pain that's going on here. An ovarian cyst, generally, unless the patient has multiple ovarian cysts, which is unusual, it's going to be on one side or the other. It's also going to be in the lower quadrants of the abdomen. And again, like we said earlier, ruptured ovarian cysts generally always come about as a result of sexual activity. If it's PID, this lady she's just not going to be able to have intercourse because of the amount of pain that would cause. Excellent. Very, very good. All right. Yes, ma'am.
Can you go over the signs and symptoms of ectopic pregnancy versus the ruptured ovarian cyst?
Absolutely. Absolutely. So ovarian cysts, depending upon where they're at, the ovarian cyst could potentially cause a patient to have some signs and symptoms of pregnancy. Generally, the only one that they would have would be the possibility that it may interrupt their menstrual cycle. With an ovarian cyst, generally what's going to happen is you're going to have this pain that is going to come on suddenly, okay? And most of the time it's going to come on either during sexual activity or number two, during exercise because you're working the abdominal muscles. With ectopic pregnancy, the hallmark signs are going to be number one is a missed menstrual cycle because the patient is indeed pregnant. It's just not implanted in the right place. Second thing would be at about 6 weeks, the patient will begin to often complain of breast tenderness because of hormonal changes. At about 6 weeks, she will also begin complaining of potentially morning sickness if she's going to have morning sickness. Now, here's the thing that we're going to see at about the 4 to 6 week mark is that we will have unilateral abdominal soreness that increases in intensity that never lets up. Why is that? It's because as the fertilized egg continues to grow and to multiply, it's getting larger and it's beginning to stretch out and cause pain within that fallopian tube. At a certain point, if the patient does not seek medical care and the fallopian tube ruptures, now she can bleed to death because the fallopian tubes are very vascular. The other thing to remember is that if a patient has multiple ectopic pregnancies, it also increases the chance for more ectopic pregnancies because of the scar tissue that develops within the fallopian tubes. Does that help? Good. Any other questions? You're asking good ones today. All right. Kara, which of the following is not a complication of hypothermia in the pediatric trauma patient? A, inhibited clotting cascade. B, release of anticoagulant agents. C, reduction in blood loss. Or D, increased energy use. So take two of those out for me, please.
A, A. For no complication.
We'll take A out. What else? Now, one of the things I want to stress to you is when we're doing a review like this, if you truly, truly don't know, that's always an appropriate answer because I would much rather you say, I don't know, than guess it and maybe get it right. So if you get to that point, Kira, it's okay.
I'm gonna go A and B.
All right, we'll take A and we'll take B out. Now you're left with C and D. I will tell you, one of those is the right answer.
I'm going to go with
C, Charlie? D, Delta. Okay. It's actually going to be a reduction in blood loss. Let's think about this now. Okay. You've heard me harp way back with trauma. Now you've heard me harp in here about the importance of keeping your pediatric patient, all your patients, warm. Because what happens, number one, is that the clotting cascade does get inhibited. Now, when we talk about a clotting cascade, and this is for anybody, what does that mean? Bella.
Clotting ability.
We haven't dug into it much in trauma as well as in here because it's not critically important for you to know, but there is multiple steps that take place as clotting begins to occur. And that clotting process, just like Bella said, does get inhibited because the patient is now cold. So that slows that down, which ultimately leads to more blood loss. So one of the big things that we're looking at here is we got to keep our patients nice and toasty warm because otherwise they're not going to clot off. And if they don't clot off, what's the end result? Now they begin to bleed more. Any questions on that? That's really, really important as far as your trauma patients, regardless of the age is. Kara.
So I was thinking increased energy use because if you've got a trauma patient who's becoming hypothermic, I'm kind of viewing it as they're in decompensated shock. Like they're going to not be able to compensate much longer. So I was thinking, like, if they're at that point, why wouldn't it be increased energy use since they can't keep up with the demand?
So now remember, in here it says which one of these is not. And generally what happens if our patient is hypothermic, they get into this downward spiral of where they're going through energy faster and faster and faster than if they're warm. A couple things happens here. Number one is they're using that energy faster. And the second thing that happens is that ATP, which we know is the fundamental building blocks of energy, is being produced at a much lower rate. So that means what is being produced is being used up. So in this situation, increased energy usage actually is a correct answer. Anybody else? All right. Next up, a woman with severe lower abdominal pain, a temperature of 102.4, and skin that is pale and sweaty. She says she had an elective abortion 72 hours earlier and has had bloody vaginal discharge ever since. You should. There's those two words there, okay? Again, when you say you should, remember just put the word next in there. You should next. And of these four options, which one are you going to do immediately next? A, start IV fluids, oxygen, and transport. B, place in a position of comfort, pain medication, and delayed transport. C, do a detailed secondary exam on a 12-lead EKG. Or D, position in a knee chest position and rapid transport. So what I want you to do is to eliminate two of those wrong that you feel like are wrong.
Charlie and Delta.
All right, we'll take Charlie and Delta out. Of A and B, which one do you like better?
A.
Tell me why A is the better answer.
Just going off of what the question tells us, she is diaphoretic, she's a little bit shocky, and she has a fever. So, given that she's in the early stages of shock, active oxygen, those fluids are going to help probably bring down the fever and improve her pressure. And then she obviously needs the hospital, so transport.
So for the bonus points, what kind of shock is she in?
Probably hypovolemic because of the blood that she's lost.
Okay. What about that right there? Do you see an elevated temp in hypovolemic shock?
No, you'd actually see hypothermia, so that makes me think more septic shock.
So don't let me lead you down the wrong path.
Okay.
I think it's probably a combination of both hypovolemic and septic shock. So again, how do we know? Because she's got signs and symptoms of shock. She's pale and sweaty. She had an abortion, so this is, it's an elective abortion, but it's a surgical procedure. And the thing to remember is in situations like this, think of that surgical procedure as kind of trauma to the body, which it actually is. It's therapeutic trauma, but it is trauma. But it also says that she's had a bloody vaginal discharge ever since the therapeutic abortion. So I believe you're right. I believe it is hypovolemic shock, but I also believe because of the increased temp, that we're probably got some septic shock going in there because of some tissue that might have been left. Good job. Good job. All right. Joe, we're going to start over here with you on the next one. You're caring for a 7-year-old in VFib. The child weighs 19 kilograms. You just delivered your first shock, and another paramedic reports that she's obtained IO access. You should direct the paramedic to administer what dose of epi? A, 1.019 of 1 to 10,000. B, 1.9 milligrams of 1 to 1,000. C, 0.19 milligrams of 1 to 10,000. Or D, 0.019 milligrams of 1 to 1,000.
I'm going to get rid of B and D because 1 to 1,000 is used for anaphylaxis and not
I love being around smart people.
stuff. And then I'm going to go with C.
Good job. Good job. Yeah. So when you're given epi here in this particular situation, Joe, what are you hoping to accomplish? Little pharmacology review.
To help the heart start going again.
Okay. Yeah, so the patient is in VFib. What we're hoping to do is to try to make that VFib more coarse to maybe convert it into something that is perfusing. Okay, good job. All right, Sam. Woman presents with severe unilateral abdominal pain and vaginal bleeding with signs of shock. She makes a statement. There's no way I'm pregnant. I have an IUD. Which of the following is the most likely cause of her condition? A, endometriosis. B, pelvic inflammatory disease. C, miscarriage. Or D, ectopic pregnancy.
I'll eliminate A and C.
A and C are gone.
And then I'll go with D.
So what is it, and this is for anybody, that A, B, and C have in common?
Diffuse.
Say it again.
Diffuse pain.
The diffuse pain. So we would see widespread abdominal pain. With an ectopic pregnancy, we would have one-sided pain in the lower quadrants. With both endometriosis, pelvic inflammatory disease, and miscarriage, we would see pain in all quadrants, both the upper and the lower. Good. Tom, which of these is true regarding vaginal delivery? A, infants delivered vaginally are at greater risk of post-delivery complications. B, the compression of the infant's chest during vaginal delivery aids in the removal of fluid from the fetal lungs. C, vaginal delivery stimulates the production of insulin in the newborn. Or D, the foraminal valley closed more successfully in newborns delivered vaginally.
I think it's not A and D.
Okay, so we'll take A out. We'll take D out.
I think it's B.
Yeah. So remember, as the baby is being born, it's passing through the pelvis, and that whole process presses the lungs. Does two things. Number one is it helps to expel amniotic fluid from within the lungs because they haven't used. Second thing is it increases the pressure, which triggers the baroreceptors within the brain to now say, okay, kid, now you're going to have to start breathing on your own. Excellent. This is one of the reasons why children or babies that are born prematurely are very small to begin with, and they first of all their pulmonary system is not developed nearly as well as what they would be if they're full term. But number two, because of how small they don't get that compression. So we still have fluid in the lungs, and they're not stimulated to breathe. Austin. All the following are associated with spontaneous abortion except A, non-traumatic vaginal bleeding, B, the passage of clots and tissue, C, hypotension and fever, D, cramping and abdominal pain. Take 2 out for me.
Get rid of B and C.
Okay, we'll take B and C out.
A.
So with this, it's actually going to be hypotension and fever. Now, we can, remember, this is a spontaneous abortion, all right? A spontaneous abortion comes about as a result of no trauma being involved. Basically, the body recognizes that the fetus is probably not going to continue to develop and it's not going to be able to survive, so it expels the tissue. So we can have vaginal bleeding as a result of a non-traumatic reason, okay? The passage of clots and tissue, definitely going to be there. Cramping, abdominal pain, definitely going to be there. Most of the time, remember, this was only talking about spontaneous abortion, which makes this one a little bit different than the question that you had, in the fact that a spontaneous abortion is generally fairly quick, that it happens in hours. So even if there is some tissue that's left there in the process of the abortion taking place, it's not going to be there long enough yet for sepsis to have developed. So most of the time, we're not going to see that elevated fever. We will see hypotension, potentially, because of the amount of bleeding that mom is going through. All right? Jonah, your patient is a 16-year-old female cheerleader who fell and struck her forehead. She has a 2-centimeter laceration just above her right eyebrow. She's tearful and asks you if you think she's going to have a scar. Which of these is the best response? A, it's a small cut. The emergency department will do everything they can to minimize scarring. B, I really can't say. You should probably see a plastic surgeon. C, a doctor can provide a prognosis when the cut has healed. Or D, it's likely, but it's not something to get upset about.
I'd toss B and D. I think A is the right answer.
Yeah, so A is not only the most compassionate answer, but A is the most truthful answer as well. You know, particularly for young people, or for anybody in that matter that has any type of a facial laceration, most likely, unless it's just a little tiny thing that's going to require a couple of stitches, and maybe if it's near the hairline, they're going to call in a plastic surgeon to come, if one's available, to come in and do that suturing, just simply because of the potential for disfigurement. But you're exactly right, Jonah. The ED will do everything they can to minimize anything that's going on. B isn't really correctly, because again, we're making a referral when in reality we shouldn't be doing that, because that now basically decreases her confidence and trust in the ER staff. C isn't correct, because they'll be able to look and see what the prognosis for scarring will be as before it even heals. And then D is just, that's cold hearted. That's just, you don't say that to anybody, regardless of their age. All right, Bella. Your patient is a 42-year-old woman who is complaining of vaginal bleeding. She states that bleeding began 10 hours ago and is heavier than her normal flow. Her last menstrual period was 3 months ago. She's G3, P3, and there's no other history. Which of the following is most likely cause of her signs and symptoms? Now, real quick, tell me what G3, P3 means.
She's been pregnant 3 times and she had 3 successful children.
Perfect. So, which of the following is the most likely cause of her signs and symptoms? A, ectopic pregnancy. B, pelvic inflammatory disease. C, menopause-related dysfunction, uterine bleeding. Or D, spontaneous abortion. So take 2 out for me.
Get rid of B. C.
Okay. So of A, ectopic pregnancy, or D, spontaneous abortion, which one do you like better?
Actually, I think it might be C.
Say it again.
I think it might be C.
Think it might be C? Tell me why you think it might be C.
Because she's 42. Just what happened. Menopause. I'm not really sure.
Okay.
I feel like I wish there was like more like that described like what her bleeding felt like, but
So let's take a look at this one. So your best answer is actually going to be a spontaneous abortion. So let's think about this. Again, what you just said about I wish there was more information there is critically important because it's not there, and don't read anything into it because it can take you down if you're reading, if you're functioning as a clinician, which is what I want you to do when you're on the street. But if you're taking this particular exam, you're just simply looking at only the facts that are in front of you. So what do we know? Okay. 42-year-old female complaining of vaginal bleeding. Okay. Started about 10 hours ago and it's heavier than her normal flow. Now, here's the thing. Her last menstrual cycle was 90 days ago. That would be highly unusual for a female who is going through menopause, which she could potentially be going through at that particular age. But remember, it says menopause-related dysfunctional uterine bleeding. In that situation, if she was bleeding from the uterus itself, it would most likely have pain, which would have to be reported in the question. So thinking back again to the physiology of uterine dysfunction, remember if we're getting bleeding coming from the uterus, we're probably going to have pain because the uterus has lots of nerve endings in it. So in this particular situation, it's probably going to be a spontaneous abortion just simply because of the fact that her menstrual cycle was 3 months ago. So she's probably pregnant. What are other questions that you would want to ask this lady in this situation, other than the information that's already been given you? Allie?
If she's sexually active.
Is she sexually active? That's important.
She's had previous abortions.
If she's had previous abortions, spontaneous or elective, okay, good. What else?
If she's had any like complications.
Any previous complications that's going on. Okay. Now, in this particular situation, we know the answer to all 3 of those questions is no, there's not, because it tells us in the scenario that there's no other history. Now, one of the things that's to stress to you is that both on my exam questions and on the registry, when you read something it is the gospel truth. So when this lady says she's had no other problems, you can take that to the bank. Another thing that we look at, particularly with if we're looking at a situation of maybe a trauma situation at like a bar or something, if the scenario, Tom, says within there, patient denies previous use of illegal drugs, we all know in our minds people lie to us all the time. But I will tell you, in these questions and in your registry questions, if that statement is made, they're telling the truth. They're telling the truth. Okay? All right. Alexis. Factors that stimulate the newborn to take the first breath include all of the following except A, hypothermia, B, hypoxia, C, hyperglycemia, D, acidosis. Say it again now. Is that the one you're going to go with? Tell me why you're selecting that one over the other three.
I wouldn't think the sugar level would have anything to do with them wanting to take the first breath.
So you're 90% right in your statement. First of all, hyperglycemia is the correct answer. But now here's the thing. Sugar level would have something to do with taking their first breath if it were low. Okay? Because remember, with a low blood sugar, it's going to stimulate the sympathetic nervous system, and that's going to help to stimulate the breathing. The high blood sugar, not so much. Okay? So hypothermia, hypoxia, and acidosis are all things that are uncomfortable to this child, and that's what's going to help stimulate them to breathe. Now, we look at this and we say hypothermia, and you're thinking, Billy, you just said don't let your baby get cold. And that's true. But remember, and the process of the baby being delivered from the mom and coming out into this cruel world, the baby's going to get cold until you dry it off and you wrap it up. That hypothermia that it's experiencing will actually help to stimulate the breathing that's going on. Excellent. Allie? 16-year-old female presents with complaints of abdominal pain and dizziness. She's pale and clammy and reluctant to answer your questions regarding her sexual activity. Vital signs are BP 92/62, heart rate 102, and respirations of 20. You should. There's those words again. You should. A, make it clear that she must be honest about her sexual history. B, start a large bore IV and transport emergently. C, ask the mother if the patient might be pregnant. D, transport in a position of comfort. Take 2 out for me.
A. D.
All right. Were you left with B and C? Which one of those do you like better?
B.
Why is B the better answer?
You should. That's like the next thing that you would do. Her blood pressure is low, so you're going to want to start fluids. You have to get an IV to do that. And at that point, she's very reluctant to give you any history, so there's nothing else to do besides start transport.
Excellent. Good. Yeah. A is a goofy answer. Make it clear that she must be honest about her sexual history will be the quickest way to get this young lady to shut down and not give you any information about any history, sexual or otherwise. Okay? So in that situation, it's kind of like if she doesn't want to answer, that's fine. We will go with what we have. We're not going to ask the mom if the patient might be pregnant because mom is not going to, if she suspects it, she's probably not going to admit to it. And mom may not know. So the biggest thing that we've got here is that we got a shocky patient. Now, let me ask you, Allie, compensated, decompensated, or irreversible shock?
Decompensated.
Why?
The
blood pressure.
Okay. I would tend to agree with you. Again, we don't know how large or how small this young lady is. If she's a petite person, that potentially could be her normal blood pressure. But in this situation, the fact that she's pale and clammy tells me that we've gone beyond compensated and blood's beginning to be shown away. Excellent. All right, next up. Which of these best describes the appropriate timing of the rapid pediatric trauma assessment? A, after the focused history and assessment of the stable trauma patient. B, after establishing airway ventilation and hemorrhage control in a critical trauma patient. C, upon making initial contact with the unresponsive trauma patient. Or D, when considering accepting a refusal of treatment and transport from a stable patient. So, which one do you think? We'll throw this one out to the crowd. What would you eliminate?
D.
So we'll eliminate D. Okay. What else would you eliminate? So remember, it's asking the timing. When are you going to do the rapid pediatric trauma assessment? What else would you kick out? All right, we can kick it out. So, Allie, you've taken control of this one. That's fine. What do you like as far as the two answers that are left?
I go with C.
Okay, so now remember with this, with your initial contact, if you've got an unresponsive trauma patient, what kind of assessment are you going to do when you make your first contact? Is that going to be your rapid trauma assessment or your initial or your primary assessment?
I guess primary. I just think rapid because you would be fixing those things as you're assessing what you're doing B. Rapid assessment.
Right. So basically in here, B and C are kind of opposite of each other. And what they're looking at here is that, first of all, we got to get our ABC and hemorrhage. And hemorrhage is part of C. We got to get that taken care of in order for us to be able to move on to our secondary assessment or that rapid trauma assessment. All right, ladies and gentlemen, we've been going for about an hour now. We're going to stop there.